Welcome back to Synapse, and this is Ritika. Today we'll talk about inflammation, specifically about acute inflammation. First off, what is inflammation? It is a protective response which is put up by the host tissue against any kind of noxious stimulus. Now, this noxious stimulus could be infection, it could be infection by any kind of pathogenic organism, could be because of trauma to the host tissue because of physical or chemical agents. It could be necrosis because of ischemia or any other causes. It could be foreign bodies present in the body, right? Such as sutures, splinters, probably even dirt particles. And also, we have a few immune responses like hypersensitivity reactions or autoimmunity reactions, where this kind of inflammation in these kind of situations is more troublesome than helpful. So, when there is any of these kind of causative agent present in the body, the host tissue, different types of host tissues, trying to communicate with each other via a few chemical mediators. Now, with the help of these chemical mediators, they're trying to bring the immune system to the site of inflammation and try and eradicate or to ward off the causative agent. One thing you should remember is that though inflammation is a protective response, it comes with some amount of collateral damage. It's like a two-sided coin. So the chemical mediators which are released by the host tissue and also by probably the pathogenic organisms, it's going to cause some amount of damage to the surrounding normal host tissue. So the extent of this damage to the surrounding host tissue depends on how intense is the inflammatory reaction happening in that site.
The topics discussed in this video and the time at which it is discussed is given in the description box below. If you want to, you can skip forward to the specific topic.
We'll now look at the cardinal signs of inflammation, which includes heat, that is warmth which is seen in the region, called as the calor, the redness referred to as the rubor, swelling or the tumor, pain or the dolor, and the loss of function. The first four among these were described very, very long ago by a Roman encyclopedist called Celsus, while the last one was added only recently by Virchow, the father of modern pathology. So now let's look at the classification of inflammation. Now, if the inflammatory reaction is able to remove the causative agent very quickly, then it will remain acute inflammation. But if the body is not able to remove the causative agent and persists in the body for longer duration, then it will lead to chronic inflammation. Further on, we're going to talk only about acute inflammation. So, as the name suggests, acute inflammation is what lasts for shorter duration of time, and we know that this is majorly associated with neutrophilic infiltration. In contrast to the chronic inflammation, which is for longer duration, and there is more of mononuclear infiltration seen in the chronic inflammation. The first step in acute inflammation is recognition of the stimulus. The body should first of all understand that there is something happening at a particular site where the inflammation has to be brought about. So for that purpose, we have two main things we're going to be talking about now. That is toll-like receptors, the toll-like receptors and the inflammasomes. The toll-like receptors are going to recognize the microbial antigens. They present on the plasma membrane, also on the endosomes. So they can recognize the extracellular pathogens, also the internalized pathogens. They recognize these and they will bring about activation of a few transcription factors, which will cause the release of a few cytokines, which help in leukocyte activation and attracting them to the site of inflammation. And also we have inflammasomes. Now inflammasomes are going to recognize the products of dead cells, such as uric acid or extracellular ATP. Now as it recognizes this, it does something really interesting. As inflammasomes are activated, it will cause activation of interleukin 1. And we know that interleukin 1 plays a very important role in leukocyte attraction and activation. Here, about inflammasomes, I would like to mention its role in gout. We know that there is uric acid crystallization happening in the joints. Now, because there is uric acid crystallization, the phagocytes here are coming and engulfing this. Now, these phagocytes, because of the engulfment of the uric acid, it's causing the activation of inflammasomes. Now, because there is activation of inflammasomes, there's a lot of interleukin 1 release. This interleukin 1 is going to attract more and more leukocytes to the site, causing more and more inflammation and more reaction, more and more problem. The second step we have are the vascular changes. So over here, the first thing we'll see is that there is some transient vasoconstriction. The motive of this is to keep the blood loss minimum. And this might remain so only for a few seconds. This is followed by vasodilatation, which is more prolonged. And the motive of this is to allow more inflammatory cells and proteins to reach the site of inflammation. And this is the cause of rubor, that is the redness seen in inflammation, and the calor, which is the warmth at the site of inflammation. The next thing we're seeing is increased permeability. Now, because of increased permeability, a lot of substances are moving out of the vessels into the extravascular tissue, because of which the concentration of the blood inside the vessel is increasing, which means there is increase in viscosity. So the movement of the blood over here is going to become more sluggish, that is, there will be stasis. So what you will see is that the vessels in the area of inflammation is all engorged and it's all like stuffed with RBCs and cells basically. It's all concentrated and there is stasis. Now, because of this alteration in the hemodynamics, there is disruption of the laminar blood flow. Now, what is laminar blood flow? Let's say this is a blood vessel and we have the WBCs going around in the center, as they're the largest cells there in the center. Peripheral to them, we see the RBCs, the red cells, peripherally. And more peripherally, you see the platelets, which are much smaller structures. And then you have some space which is cell-free plasma. And this is going to prevent the cellular contents from normally coming and colliding with the endothelium or the vessel wall. But now that there is loss of all this fluid into the extravascular space, these cells come closer to the vessel wall. So you see that the leukocytes are coming closer to the margin, and this is what is called as margination. The margination is the primary step in the cellular changes which are seen in inflammation. Let's here have some deeper discussion on the increased vascular permeability. Now, because of this, there is a protein-rich fluid escaping the blood vessels, and which is called as an exudate, in contrast to the transudate, which has lower protein content. But now, whether it is an exudate or transudate, the moment it accumulates in the extravascular tissue, it accounts to edema. Now, the edema associated with inflammation is where we see the exudate. The edema where there is no inflammation, that is non-inflammatory conditions, we see transudate causing the edema. So now let's look at the mechanisms by which there is increase in vascular permeability. First, there is a transient action of endothelial cell contraction. So normally we have the endothelial cells lying next to each other like that. But in contraction, you see that there is gaps created between the cells, so there is increased permeability. But this is not a change which is long lasting. What is long lasting is what's called as the endothelial cell retraction. In retraction, we are seeing cytoskeletal changes in the endothelial cells. So this is more permanent or long lasting. So there is increased permeability. These two phenomena is more common in the post-capillary venules. Another thing that could be happening is injury to the endothelium. So, as can be very clearly understood, if when there is damage to the endothelium, there is definitely increased permeability. This could happen in the arterioles, the capillaries, in the venules, anywhere. Next thing is increased transcytosis. There's something called transcytosis, where if this is one wall, we have the cells, and the contents are moving across the cell, like through the cell, via vesicles, intracellular vesicles. So this is called as transcytosis, and this is a mechanism which again may lead to increased vascular permeability, mainly seen in the venules. Another thing are newly formed blood vessels. As these newly formed blood vessels are not matured yet to have complete functionality like a mature vessel, it's going to have greater vascular permeability when compared to a mature vessel. So there is some amount of leakage of the plasma from the newly formed blood vessels. We spoke about the blood vessels till now. What happens to lymphatics? Whenever there is inflammation or edema at a site, there is increased lymphatic flow, which will try and take away the inflammatory cells and the fluid out of the edema or the inflammation. But along with that, it may also take some offending agents, especially when there is pathogenic organism which is present there. So now, as the pathogenic organism is also carried away into the lymphatics, it's possible that there is inflammation of the lymphatics, which is called as lymphangitis, right? Which is inflammation of the lymphatic vessels, or it may go and drain into a lymph node, and it may cause inflammation of this, which is called lymphadenitis. When there is lymphangitis seen, it is seen as clear red streaks on the skin near the inflammatory region, and it is almost very diagnostic for lymphangitis. Okay, so this is how the red streaks look. Next, we will see the cellular changes. The first thing occurring here is margination. We've already discussed as to what is margination and how it is occurring. Just in short words, the WBCs which are normally present in the center of the blood vessels in the laminar blood flow, because of the disruption of the laminar blood flow, is going to come closer to the endothelium, and this is called as margination. About rolling. Now, what is rolling? Let's say this is the blood vessel and we have the WBCs close to the endothelium, that is, margination has already occurred. It's going to roll over the endothelium. This is because of some loose adhesion. Loose adhesion between the WBCs and the endothelial cells. And also there is some force of the flowing blood, which is going to cause the WBCs to roll over the endothelium. Now, this loose adhesion, how is this brought about? So let's say this is our endothelial cells, and these are our WBCs. So on the endothelial cells, we have a few adhesive molecules which are called as selectins. And we have the complementary molecules present on the WBCs called as sialyl, Lewis, X factor. So it is interaction between these two molecules which brings about loose adhesion, and thus there is rolling. What's important for us to know here with respect to understanding and also about MCQs is that where are these selectins present when they're not needed? So they normally, when they're not needed, they present inside the endothelial cell. There are bodies, there are some bodies, right? They're called as Weibel-Palade bodies. And these Weibel-Palade bodies contain the selectins inside them. And just to add on to the information you need to be knowing about Weibel-Palade bodies, one, it contains selectins in their low energy form, that is in inactive form, and it also contains von Willebrand factor. About selectins, there are three types of selectins. We have E selectins, P selectins, and N selectins. E selectins are commonly seen on the endothelial cells, and we have the P selectins seen on platelets and also on endothelial cells, and N on neutrophils. The N selectins have the function of helping in the homing in of the leukocytes into the lymph nodes. So after rolling, we have adhesion. So adhesion is where there is tight adhesion or tight forces holding the WBCs onto the endothelium. So there is no more rolling, and there is different molecules which are involved in this kind of adhesion. So we have again a few molecules expressed by the WBCs and a few by the endothelial cells. On the WBCs, we normally have these molecules called the integrins, right? Adhesion is mainly mediated by integrins. So these integrins are present in low affinity form on the WBCs. On the effect of cytokines, these molecules get clustered together in order to form a high affinity unit. And similarly, on the endothelial cells, we normally do not have the complementary molecules expressed on the endothelial cells. So it is expressed only on effect of cytokines. So they express the complementary molecules such as ICAM and WCAM. So now let's look at the interaction between the molecules on the endothelial cell and the WBCs. So we have ICAM1, which is one of the examples of a complementary protein to integrins present on the endothelial cell. So it corresponds to intercellular adhesion molecule 1. And this has interaction, or it binds with leukocyte function associated antigen 1, also called as CD11A, CD18, and also with macrophage 1 antigen, also called as CD11B, CD18. The next molecule we have on the endothelial cell is WCAM1, which is called as the vascular cell adhesion molecule 1, which has interaction with very late antigen 4. So the next thing we have is transmigration, also called as diapedesis, where the WBCs are going to cross the endothelial cell membrane cell layer and also the basement membrane and enter into the extravascular tissue or extravascular space. This is called as transmigration. This is mainly occurring in the venules region in case of systemic circulation, and it may also be seen in the capillaries in the pulmonary circulation. And what we need for this process are two substances. So one is a molecule, cell adhesion molecule, which is called as PCAM1, also called as CD31. PCAM stands for platelet endothelial cell adhesion molecules. So now this molecule is going to help in the necessary interaction that is required in order for the transmigration to occur. The second substance you need for this is collagenases. Now these collagenases are going to help in dissolving the basement membrane and enter into the extravascular tissue. So the next event here is chemotaxis. What is chemotaxis. Now let's say this is the actual site of inflammation while we have some blood vessels here. Now the WBCs have already come out of the vessel and let's say they're somewhere around here. Now, how do these WBCs know that they need to move in this direction and not wander off somewhere else? This unidirectional movement of the WBCs is brought about by a certain set of chemicals which are called as chemotactic agents, and this unidirectional movement is itself called as chemotaxis. So how exactly is this chemotactic agents actually helping us? Here is our WBC. Here is a site of inflammation. Blue is going to represent our cytokines. The cytokines are at higher concentration closer to the inflammation. And this concentration is going to decrease as you go away. So that means that on this side of the WBC, there is higher concentration of cytokines than on this side. So the WBC is going to move closer to the side where it sees more cytokines coming towards it. So it's going to move towards the site of inflammation by this. There'll be some amount of cytoskeletal changes, there'll be pseudopod formation, and it's going to get drawn closer to the site of inflammation. Now, what are these chemotactic agents that we are talking about? First off, we have the bacterial products. This is an exogenous chemotactic agent. And then we have the complement proteins such as C5a, mainly C5a. We have some chemokines such as interleukin 8 and also the metabolites of lipooxygenase pathway of arachidonic acid, especially leukotriene B4. So what we have spoken about till now, can we recap with this simple diagram? So the first thing we spoke about was margination, where WBCs come closer to the endothelium, and then there is rolling, and then there is adhesion, and then there is transmigration, and then there is chemotaxis. Among this, the margination, rolling, and adhesion are intravascular changes, while transmigration and chemotaxis are the extravascular changes. This is followed by the most important activation of leukocytes, where this leukocytes are going to get activated, it will phagocytose and try and kill the causative agent. So now that the leukocytes have reached the site where we have the dead tissue and the microbes, we wanted to get activated. So what happens after the activation, or what is it? So there will be phagocytosis of the dead and the microbial tissue. And then there will be intracellular destruction of those engulfed tissues. Then there will be liberation of a few substances which will help in extracellular killing of the microbes and the dead tissues. And in this, we have a new concept called as neutrophil extracellular trap, which we will talk about in detail. And then there is production of mediators, which will help in getting more neutrophils and leukocytes to the site of inflammation. We'll have a little discussion about each of them. In phagocytosis, the first thing we're going to look at is recognition and attachment to the microbial antigen. Now let's say this is a phagocytic cell and we have a microbe. This microbe has some antigens on it, right? So let's make a receptor for this. So this is mainly mediated by almost specific receptors for the antigens. So this will help in recognizing and attaching to the microbe. But in another scenario, what can happen is this is my microbe. This gets coated by a few host proteins, right? They get coated by a few host proteins. And these host proteins are going to be recognized by the receptors present on the phagocytic cells. And these intermediate proteins, which is going to enhance the phagocytosis, is called as opsonins. So the opsonins makes the antigen or the bacteria more tasty for the phagocytic cell. The common examples of opsonins we need to know is IgG immunoglobulin and C3b complement protein. And this entire process of making phagocytosis more effective by the action of these opsonins is called as opsonization. This is followed by engulfment. Now this engulfment happens because of some pseudopod formation. So this is the phagocytic cell and it has recognized the bacteria here. There will be pseudopod formation. And this pseudopod formation is because of polymerization of the actin here. There is polymerization of the actin and then pseudopod formation, and finally this will lead to engulfment of the bacteria. And the vesicle in which the bacteria is contained is called as the phagosome. Now what happens next is that there should be killing of the ingested microorganism. So for that, the first thing and the most important thing that's happening is the fusion with lysosome. There are some bodies called the lysosomes which are present within the phagocytic cell, which contains many enzymes. So this is a lysosome. And let's say this is a phagosome. There is a fusion of this. For this fusion of the phagosome and the lysosome, we need a protein which is called as lysosomal transport protein. Lysosomal transport protein, also called as LYST protein. So when there is deficiency of this, it results in Shediac-Higashi syndrome. These lysosomes gives us the enzymes which help in production of bactericidal products. Among the bactericidal products, the most important ones are the reactive oxygen species and the lysozymes. So in the reactive oxygen species, so about that, what we need to really know about is respiratory burst. What is respiratory burst? When there is phagocytosis, there is a increase in the oxygen consumption. There is a shoot in the oxygen consumption. This is because we need oxygen for the production of reactive oxygen species, and this by oxidative damage causes damage to the microbial cells. So how is this reactive oxygen species formed? So we need an enzyme which is called as NADPH oxidase. NADPH oxidase oxidizes the NADPH, in the process of which it is going to reduce oxygen to superoxide radical. This superoxide radical, by the action of dismutase enzyme, gets converted into hydrogen peroxide. And hydrogen peroxide, by the action of myeloperoxidase, gets converted into hypochlorous acid, and this is a very potent reactive oxygen species. In the very similar way, we have reactive nitrogen species also helping in the same process. And there are a few other oxygen independent killing happening with the help of lysozymes, lactoferrin, and major basic proteins. So until now it was about phagocytosis and intracellular killing of the microbial agent. Another mechanism by which it can kill the microbial substances is to secrete the microbicidal substances. That is, the lysosomal contents are put out of the cell. Now, this could cause damage to the other cells also. The next thing we'll talk about, which is very important for us to know, it's a new concept, is about neutrophil extracellular trap. So in the case of very high bacterial load, example in sepsis, we see that the neutrophils, we know that they have chromatin like this, right? So this chromatin is going to be embedded with a lot of microbicidal substances, and this is going to be thrown outside the cell in this manner. So now this has a very high concentration of antimicrobial substances on it. So let's say here we have some bacteria which gets trapped here, and that's what's called as neutrophil extracellular traps. But the problem with this is that as this neutrophil cannot take its chromatin back into the cell, it means that 1, yes, there is killing of the bacteria, 2, there is also killing of the WBCs. And another problem here is that now that you have put the nuclear material out, there could be anti-nuclear antibodies. So there could be autoimmunity and several other such problems. Now the last thing we'll talk about in this video will be some defects pertaining to the leukocyte function. So first, about the rolling and adhesion, we have a few leukocyte adhesion disorders like LADs. We have two types, LAD1 and LAD2, that is leukocyte adhesion disorder 1 and 2. LAD1 pertains to the functioning of integrins, where we have some defect in the CD18 beta subunit of the LFA1 and MAC1 antigens. And in LAD2, it pertains more to the selectin functions. So there is a defect in the fucosyl metabolism pathway, and thus there is a defect in the production of sialyl Lewis X factor. The next defect we'll be talking about is about the NADPH oxidase deficiency. It will lead to chronic granulomatous disease. And here we conclude the topic of acute inflammation. If you found it useful, do like the video and subscribe.